speaker of today. Dr. Veronica Flood is a pediatric hematologist and researcher at the Medical College of Wisconsin in Milwaukee, United States. She received her medical degree from Tufts University School of Medicine and went on to complete a residency in pediatrics at Phoenix Children's Hospital and a fellowship in pediatric hematology oncology at Oregon Health and Science University. Dr. Flood's academic career in hemostasis research includes work on the biology of von Willebrand factor. She is mostly interested in how von Willebrand factor interacts with two of its main partners, platelet glycoprotein 1 and collagen. Since collagen is exposed at sites of blood vessels injury, the von Willebrand-collagen interaction is an important component in this hemostatic step. She's also very interested in genetics of von Willebrand disease. Through collaboration, for example, with her mentor, Dr. Montgomery, and the Zimmerman Program for the Molecular and Clinical Biology, she has worked on characterizing genetic changes in von Willebrand with particular attention to variants that affect platelets and collagen binding. She is heavily funded and widely published. She has NIH, NHLBI, and Blood Institute funding since 2010 and has been awarded KO8 awards, transitioning to RO1 grants for the ones used to NIH funding lingo. Now, without further ado, let me open the session, The Changing Landscape of von Willebrand Disease Diagnosis. Veronica, it's a pleasure to have you with us, and the floor is yours. Welcome.
Thank you, and I'd like to thank Dr. Brandow for the opportunity to speak today. It's a little interesting for me since I cannot see anyone, so I'm going to assume that there's somebody listening into this presentation, and we'll hope for the best. I also hope that everyone can actually see my slides, and I'm assuming that the organizers will yell if the slides are not visible. So first, I just want to note a couple of potential conflicts of interest. I have served as a consultant for CSL Behring and Shire, both of whom make products involved in von Willebrand disease treatment, but I am primarily talking about diagnosis today. And then as mentioned, I do have grant funding from the National Institutes of Health. So a brief outline of what I want to discuss today. I was told that there may be some more junior learners listening in, so I do want to cover a little bit of background on von Willebrand factor itself, then go on to discuss some advances in our ability to assess symptoms in von Willebrand disease, a little bit about von Willebrand factor platelet interactions and von Willebrand factor collagen interactions, one of my favorite topics, and then von Willebrand factor genetics advances, the state of the field today, before ending with a clinical conundrum discussion on type 1 von Willebrand disease, more specifically the question that many of us are faced with on a daily basis, which is what is type 1 von Willebrand disease? But before we get to the interesting clinical stuff, a little bit of background so everyone's on the same page. So in terms of the biology of von Willebrand factor, it is a large multimeric glycoprotein synthesized in endothelial cells and megakaryocytes. VWF has two main functions. First, it binds platelets to injured endothelium via binding sites for platelet GP1B, and that binding site is in the A1 domain, highlighted here in blue. And then for collagen, for which there are two binding sites, one in the A1 domain for collagens 4 and 6, and one in the A3 domain, highlighted here in pink, for collagen types 1 and 3. VWF also has another important function. It serves as a carrier protein for factor VIII, and that binding occurs through the D'-D3 region, which is highlighted here in green. There are several different types of von Willebrand disease. Unfortunately, the classification system has not been simplified any further since the latest iteration about 10 years ago. It is divided into quantitative defects, of which type 1 von Willebrand disease is by far and away the most common, accounting for about 85% of patients. This is a mild or a moderate quantitative defect, so the protein is there, just not in normal quantities. Then type 3 von Willebrand disease is a severe quantitative defect where the VWF is virtually absent. This is the least common form, occurring in about 1 in a million individuals. The type 2 variants are the qualitative defects, where the protein is made but is dysfunctional. So we have type 2A, where there's a defect in VWF multimerization, type 2B, which is a gain-of-function defect causing increased spontaneous platelet binding and therefore clearance of the high molecular weight multimers and usually accompanied by thrombocytopenia. The type 2M defects, where you have a specific defect in binding to platelets or collagen, but preservation of the multimer distribution. And then type 2N von Willebrand disease, which is a defect in factor VIII binding specifically. Diagnosis of von Willebrand disease. This is the most common inherited bleeding disorder, and I just want to highlight that our best evidence on the prevalence of von Willebrand disease, the number 1 in 1,000, comes out of research done by Mackenzie Bowman and colleagues from Kingston. Women are diagnosed more frequently than men due to their ability to present with menorrhagia, but it does occur equally in men and women. Low VWF itself is present in about 1 in 100 individuals, but the true prevalence of low VWF associated with bleeding has been reported to be more like 1 in 1,000. Symptoms are generally mucocutaneous bleeding, although type 3 von Willebrand disease can present with joint bleeds. And the diagnosis is made by a personal history of bleeding, and we're going to talk more about quantitation of that, family history of bleeding, and then laboratory findings consistent with the diagnosis. And it's getting to these laboratory findings that can be a difficult challenge for many clinicians. So in terms of this problem, one of the big issues with laboratory diagnosis of von Willebrand disease is that there is no single screening test for von Willebrand disease. We have the VWF antigen, which is highly reliable in terms of telling you how much protein is there, but does not measure protein function. So if you're concerned about the possibility of a type 2 variant, which is present in almost 15% of patients, that's not going to be helpful. For years, we've relied on the VWF ristocetin cofactor activity as a surrogate measure of platelet binding. Ristocetin has a lot of problems, and fortunately there is a novel assay that does not use ristocetin that looks at direct binding to GP1B, the Innovance assay, which is now available in Canada and Europe, but not in the US. And of course, we're behind in a number of other things besides this assay. This is one of many. And then, of course, factor VIII activity. So VWF serving as a carrier protein for factor VIII and type 2N defects with a specific decrease in factor VIII binding. This is part of our screening for von Willebrand disease as well. However, there are numerous other laboratory tests available to perform confirmatory testing depending on those initial results. Multimer distribution, if you're concerned for a type 2A or 2B variant. VWF collagen binding is often not performed, but I'm going to show some evidence to hopefully convince you that this may be an issue in some patients. Gene sequencing is sometimes performed. Propeptide analysis may be helpful if you're concerned for a clearance defect. And then ristocetin-induced platelet aggregation and specific binding assays for platelets and factor VIII may be of use if you're concerned about a specific type 2 variant. These assays all have variable availability. They may not be available in every lab or be able to give you immediate results. The other problem, though, is that there are a number of conditions that affect von Willebrand factor levels. VWF is increased in inflammation, it's increased in cancer and hypothyroidism. Von Willebrand factor levels go up throughout pregnancy, and of course the one most problematic for us pediatricians is that VWF levels are increased with stress. As a pediatrician, most of my patients are stressed when faced with the opportunity to donate blood to try and make a diagnosis, and I suspect there's not an inconsiderable number of adults that also have this issue. So often we're faced with trying to interpret borderline results and wonder, was the level increased because of stress, and is it truly much lower when the patient is in a baseline state? There are also a couple of conditions where VWF levels are decreased. So hypothyroidism actually causes a synthetic defect in VWF. Cardiac valve disorders may cause an acquired type 2A von Willebrand disease, and this is of particular interest for patients that require left ventricular assist devices. And then some drugs, of which valproic acid is one, can also affect VWF levels. So with all these challenges, the diagnosis of von Willebrand disease can be difficult. So the first category I want to talk about is our assessment of bleeding. And sometimes this seems like it should be the most straightforward, but unfortunately, sometimes it's also open to interpretation. So one big issue is an issue highlighted in a recent review by Natalia Ridds and Paula James, also from Canada, which does discuss that the overlap in that bleeding symptoms do occur in healthy people. So this table shows the frequency of bleeding in healthy individuals, individuals with von Willebrand disease that was then further divided into type 1, type 2, and type 3 patients. And I just want to highlight a couple categories here, that epistaxis, menorrhagia, and post-dental extraction bleeding, as well as gum bleeding and a little bit surgical bleeding and postpartum bleeding, were found in normal individuals. Now, obviously, these have a much higher frequency in type 1 von Willebrand disease, but when you're faced with a patient who has one of these symptoms, it may be difficult to say, is this a person who has epistaxis because they have von Willebrand disease, or is this a person who just happens to be normal and happens to have epistaxis or menorrhagia or whatever their bleeding symptom is. The symptoms are much more frequent in von Willebrand disease. You can see here epistaxis was present in about 10% of a healthy population, but about half of von Willebrand disease patients. Similarly, gum bleeding was present in anywhere from 7 to 37% of the normal controls and 31% of the von Willebrand disease patients. But one bleeding symptom alone may not be as useful. So there have been a number of iterations of bleeding assessment tools. The one I have demonstrated here is the ISTH's bleeding assessment tool. The full version is available on their website, but for people that aren't familiar with it, I do want to go over for a moment how these are scored. So what I've listed here are the categories, the classifications for epistaxis, bruising, and surgical bleeding. And you get a point for symptoms. So if you have no epistaxis, no bruising, or no bleeding with surgery, for those categories you're scored as 0. If you have epistaxis more than 5 times a year or lasting more than 10 minutes, you get a point. If your bruises occur to be greater than 1 centimeter and more than 5 at a time, you get a point. If you have bleeding in less than 1/4 of your surgeries, you get a point. You get increasing points if you have a consultation with a doctor for your symptoms, if you need treatment, and then the highest number of points would be awarded if you require blood transfusion, desmopressin, or replacement therapy as treatment for whatever that symptom is. And you get a score for epistaxis, a score for bruising, a score for surgical bleeding, a score for menorrhagia, a score for postpartum hemorrhage, and all these different categories are added together to come up with a bleeding score for an individual patient. The higher the score, the more significant and the more different types of bleeding that patient has. And I'm showing here a picture of Dr. Paula James from Kingston, who has done a lot of the work on these bleeding assessment tools, of which, again, there are a number of iterations. The ISTH BAT is commonly used. The Pediatric Bleeding Questionnaire, which was developed out of Kingston, is also useful in the pediatric population. And most recently, they've developed a self-administered bleeding assessment tool. And I want to share a quote from the Rids and James paper because I think this is actually a very important idea. And in their paper, they state, our ability to predict who is not going to bleed is far superior to our ability to predict who is going to bleed. And I think this really highlights that these bleeding scores may not necessarily tell you who has von Willebrand disease, but their ability to tell you who does not have significant bleeding and therefore who may not need any further assessment can be very useful. So for example, in giving you the normal ranges for those people that don't use them. And the problem is going to always be in pediatrics. So normal children, the normal bleeding score is anything 2 or less. For normal adult males, it's anything 3 or less. And for normal adult females, they can go up to 5 and still be considered normal. And for the self-administered BAT in particular, the negative predictive value, especially in adult women, is fantastic. So if you have a high bleeding score, it doesn't necessarily prove you have a bleeding disorder, but a low bleeding score can be very helpful. Now, of course, the issue in pediatrics is that our patients have not had a lot of time to develop a bleeding score. They may not have had surgery. They may not have had other challenges. So sometimes in the pediatric population, this can be difficult. But I think in adults, especially who have had time to develop a history, these bleeding scores can be excellent tools. There is generally an increased score with increased von Willebrand disease severity. So this is taken from one of Mackenzie Bauman's papers, just showing that for type 3 von Willebrand disease patients, they have the highest average bleeding score. So the average for type 3 patients was a bleeding score of 15. Again, remember, kids, it's up to 2, men, it's up to 3, women, it's up to 5. So these are significant bleeding scores, and obviously the range went quite high. Type 1 patients had elevated bleeding scores, but not nearly in the range seen by the type 3 patients. And then they had a great control group, which was the unaffected family members who had normal bleeding scores. So in general, the more severe the von Willebrand disease, the higher the bleeding score will be. The other interesting thing that bleeding scores have been used for is to predict future bleeding. So recent work by Augusto Federici and colleagues showed that if your bleeding score was greater than 10, that was highly predictive of future bleeding that would require treatment. So in some respects, this actually validates our clinical instincts. Patients that bleed are more likely to have more bleeding. Patients that don't bleed are less likely to have future bleeding. But again, children do remain a bit of a challenging population because they may not have that history, and so it may be a little more difficult in those situations. I want to move on to discuss some laboratory issues. So first of all, assessment of VWF platelet interactions. We do have a new assay that many of you are probably already using to replace the ristocetin cofactor assay. So it's of course known that the ristocetin cofactor activity is a not great assay. It's non-physiologic because in vivo, shear stress is what initiates the VWF platelet interaction. It has a very high coefficient of variation. It's well known that this can be anywhere up to 50% between laboratories. And certainly we have a number of patients who seem to be diagnosed with von Willebrand disease due to one aberrant ristocetin level, and the rest of their testing is completely normal. And it's also affected by sequence variants in the VWF-A1 domain. The most common of these is the D1472H variant that has been shown to be associated with an increase in von Willebrand factor antigen and a decrease in the ristocetin cofactor to antigen ratio. And this is work that came out of the Zimmerman program on healthy control individuals. We took those individuals who had the 1472H variant versus those who did not have the variant and looked at ristocetin cofactor to antigen ratio on the y-axis. And you can see here that those that did not have the variant had a mean ratio of around 1. It turned out to be 0.96, while those with the variant had a lower mean ratio of 0.77. And what I particularly want to call attention to here is many people will use a cutoff of 0.6 to signify anything below that ratio is abnormal and would be indicative of a type 2 von Willebrand disease. In this normal control cohort, a fairly large number of subjects had a ristocetin cofactor to antigen ratio less than 0.6, and 3 subjects had a ratio that was actually less than 0.5. These are healthy individuals. They don't actually have any clinical bleeding symptoms, but if they had had this done as part of a workup, they might have been diagnosed with type 2M von Willebrand disease. Their issue is that they have a variant that affects the ability of VWF to bind ristocetin, but its binding to platelet GP1B is not affected. So the use of this in vitro assay is giving us a potential spurious diagnosis. There have been a couple of different options reported to replace the ristocetin cofactor assay. So there are other methods to measure ristocetin cofactor by automated methods that still suffer from the fact that they use ristocetin. You can also measure VWF binding to GP1B through a number of methods: ELISA assays, latex immunoassays, or flow cytometry with or without ristocetin. And the newest commercial one of these is Siemens Innovance assay, which is the commercial GP1B assay available in Europe and Canada. This assay uses a gain-of-function GP1B mutation and does not use ristocetin. So just to show you what's happening in this assay, there's microparticles with an antibody to capture GP1B. GP1B is shown here in green, and then this GP1B binds spontaneously to the patient's VWF, shown here in blue. The reason it does this is the introduction of these 2 mutations, the red and the purple amino acid changes, which allow spontaneous binding. So basically these are platelet type von Willebrand disease mutations that allow the GP1B interaction with VWF to occur in the absence of ristocetin. There's been a lot of work done in validation of this assay, some of which actually comes from Kathy Hayward's lab out of Canada. And it's been shown that this assay has a good correlation with the ristocetin cofactor activity assay, as shown here. greater sensitivity to low levels of VWF. It has a much lower limit of detection. The ristocetin cofactor activity in general only can go down to 10 to 20 units. This can go down to 1 to 2 units. And it's not affected, at least by that 1472H sequence variation, and one would assume that it's not affected by other variants that affect ristocetin, since the assay does not use ristocetin. This is data generated from healthy controls. They've also looked at data from type von Willebrand disease individuals with type 1, type 2, and type 3. The quantitative defects, so type 1 and 3, there is an almost perfect correlation with ristocetin cofactor. The correlation was not as perfect with the qualitative variants. One of the problems here, though, again, the 1B assay is more sensitive than the ristocetin at the lower levels, so part of this may be problems with our so-called gold standard assay here. And I put this table together just to kind of compare the two assays. I think probably some of your labs have already switched over. I know a couple of them have. We unfortunately do not have that ability to switch over here yet, but a lot of people are because of these issues. One is the lower limit of detection. As I mentioned, ristocetin goes down to 10 or 20, that's it. The GP1BM can be less than 2%. Coefficient of variation in the same lab, the intra-lab variability, is much lower for the GP1BM. It's not affected by sequence variations. It is unfortunately not available here yet, but you guys have the ability to run it should you so choose. It is still a non-physiologic assay though, and I do want to point that out, that we still don't have an assay that looks at VWF GP1B binding under shear. So this is still not quite mimicking what's happening in vivo, but it's probably the best opportunity we have to assess VWF GP1B interactions at the present time. All right, I want to switch gears and talk about one of my pet interests, which is assessment of VWF collagen interactions. So it's known that there's a couple different ways VWF interacts with collagen. The VWF-A3 domain binds collagens type 1 and 3, and then the VWF-A1 domain binds collagens 4 and 6. And generally collagens are referred to using Roman numerals, but I'm simplifying things here since we're talking about different types that look very similar to each other. Unfortunately, the collagen binding assay is not typically performed as part of a von Willebrand disease workup. When it is performed, it typically uses collagens 1 or 3 because those are the ones that are commercially available in most labs. Collagen binding is decreased with loss of high molecular weight multimers, and it's also reduced in some type 2M variants. And Emmanuel Favellaro has done a lot of research using collagen binding assays, and I've borrowed one slide from one of his papers to show that basically all the different activity assays are measuring something slightly different. So when you look at collagen binding in these dotted lines, they are not the same as ristocetin binding, which would be the line of equivalence in the dark black. So I'm going to present some data coming out of the Zimmerman program, which for those of you that don't know, was a large study that took patients with von Willebrand disease as well as their family members and healthy controls. We did laboratory testing, including antigen and activity, but also collagen binding. And when I say we, this is not work that I've personally done. This is work that our research coordinator and laboratory people perform. So Pam Christofferson is our main research coordinator, and these are some of the laboratory people that are actually performing the work that I then get to present and take credit for. We also did a bleeding score on all the subjects using that ISTH bleeding assessment tool I discussed, and then full-length gene sequencing, at least on the index cases, and then family members if we found a variant in the index case. So first I want to look at our healthy control population. So this is ristocetin cofactor to antigen ratio on the far left, and then collagen 3 binding to antigen ratio in the middle, and collagen 6 to antigen ratio on the far right for our 246 healthy controls. And of course, on average, the mean ratios were about 1. Normal ratio would be considered to be greater than about 0.6. And again, the ristocetin cofactor assay, we had a handful that were lower, predominantly due to that 1472H variant. You will notice, though, in our type 6 collagen, we had several that were low as well. Interestingly, the two lowest had the same variant in the VWF-A1 domain. Both of them had an ARG1399H variant. When we looked at our type 1 subjects, again looking at ristocetin to antigen compared to collagen 3 to antigen ratio compared to collagen 6 to antigen ratio, we found again that there was a subgroup with a very low collagen 6 result, and this actually made the collagen 6 results significantly different than those we obtained with a ristocetin cofactor to antigen or a collagen 3 binding to antigen ratio. And again, we found that same ARG1399H variant in 3 of those very low subjects. The other very low subject had an ARG1315C variant, which is also in the A1 domain. Now, in the healthy controls, all these patients were heterozygous for these variants. In the healthy controls, heterozygosity got you a level of about 50%. The type 1 subjects that had a level of 0 also had a second mutation, which was presumably the reason they were diagnosed with type 1 von Willebrand disease. And these turned out to be a variety of probable null alleles because they had also been reported in patients with type 3 von Willebrand disease. So what we presume is happening is the patient is a functional homozygote because there's no VWF coming off of that other unexpressed allele. So just to summarize the 1399H issue, this is a variant in the A1 domain out on a face, which is our probable collagen 6 binding site, showed decreased binding to both collagens 4 and 6 that was reduced in heterozygotes but absent in homozygotes, or the closest thing we have to homozygotes. About 2% of the Caucasian population has been reported to be heterozygous for this variant. This brings up an interesting question. If this many people are heterozygous, there must be some homozygous out there. And in theory, if those patients don't have any other VWF variants that would cause them to have low VWF, they could go undiagnosed and still have absent binding to collagen 4 and potential bleeding symptoms because of that. So to highlight this bleeding issue, I have a medical student who's been looking at some of the type 2M data. Ashley Dorello has looked at our type 2M subjects, of which we have far fewer. In the 2M subgroup, of course, by definition, their ristocetin cofactor to antigen ratio is low. Collagen 3 binding was normal. Collagen 6 binding, there was a group that were very low. 2 of the ones that had absent binding had mutations in the region very close to that 1399H. One was an 11 amino acid deletion that actually also took out 1399H, and the other was a 1402P that actually occurs on that face adjacent to 1399. She also analyzed this group for bleeding symptoms. Oh, sorry, there are other 2 variants that were seen. One was a double heterozygote for 1399 and another A1 domain variant, 1425F. And then the 4th subject had a 1358N variant, which again is in the A1 domain where the collagen 4 and 6 binding site occurs. So first we looked at bleeding symptoms in type 1 von Willebrand disease and subdivided this group into patients or subjects that had low collagen 6 binding versus those that had normal collagen 6 binding. Obviously there were far more in the normal category, but interestingly there was a difference in the median bleeding score. For those that had also a collagen binding defect as well as low VWF, the median bleeding score was 14. Whereas those who had just low VWF, the median bleeding score was 7. This suggests that presence of a collagen binding defect confers additional bleeding apart from just having low VWF. The same pattern was seen in our type 2M subgroup. For those with low collagen 6 binding, the median bleeding score was 13 versus those who just had a platelet binding defect, their median bleeding score was 6. I do want to point out there's a wide range here, and I do want to also note that several subjects had normal bleeding scores. Some of these were children, so it's possible that in the future their bleeding score will be higher. But not every patient with von Willebrand disease in our study had an abnormal bleeding score, so that's just one small caveat. Back to the issue of using collagen binding for diagnostic purposes. So The A3 variants, these are the specific defects in binding types 1 and 3 collagen, and these are the collagens that are found in most commercial assays. Most commercial assays use either type 1, type 3, or a combination of the two for collagen binding assays. And these patients that have been reported to have these variants have presented with either normal or borderline low von Willebrand antigens. Many have had increased unexplained bleeding, and somebody either did a collagen binding because it was part of their initial workup or for further investigation, and they were found to have an A3 domain variant and very low collagen binding. So the 5 that have been described that I found to date are 1731T, 1745C, 1761K, 1783A, and then 1786D. The A1 domain variants are the ones that affect binding to types 4 and 6 collagen. These have been reported in both type 1 von Willebrand disease and type 2M von Willebrand disease. And this actually raises the question, if you have an additional collagen binding defect, should their diagnosis be changed to type 2M since it's more consistent with a type 2 variant? So far, we've left them in their initial diagnostic category for our study. And I just want to present some statistics. So for the Zimmerman program, if you look at the subjects overall, 6% of the subjects had an A1 collagen binding defect, meaning a defect binding collagens 4 and 6, as compared to less than 1% with an A3 collagen defect, a defect in binding collagens types 1 and 3. Overall, this accounted for 5% of our type 1 subjects and 19% of our type 2M subjects. Admittedly, type 2M is the least common type of von Willebrand disease after type 3, but type 1 is very common. So 5% of the type 1 subjects is a not insignificant number, and many of these patients may have increased bleeding due to these variants. Currently, there is an available assay for purchase for collagen 6 binding. I know the blood center has been hoping to get a collagen 4 binding assay up and running. Anecdotally, we have found a couple of subjects with unexplained bleeding to have collagen 4 binding defects and normal VWF levels, so it is hypothetically possible we could be missing a diagnosis of von Willebrand disease in some individuals who don't also have a low VWF or a dysfunctional VWF allele. The next topic I want to touch on, because there's been a lot of work in this area recently, is assessment of VWF genetics. With all the difficulty in performing these laboratory assays and questions about which laboratory assay is the best one to give, I think this raises the question, is there a simpler way to do this? And many diseases now are being assessed by genetics. It would be wonderful if we could just draw some DNA, send it to the lab, and get back an answer without having to fuss with complicated bleeding questionnaires, complicated VWF functional assays that may or may not be available at your institution. And of course, this is von Willebrand disease, so the answer is not going to be that easy. Problem number 1 is the amount of variability in healthy individuals. So this is from a paper by Dan Bellissimo highlighting healthy control individuals with abnormal VWF sequence. Everything highlighted in the blue boxes was a variant found in healthy individuals that had previously been reported as a causative mutation in von Willebrand disease. One of the issues was this healthy control group contained fairly high numbers of African Americans, and so there may be some ethnic variability issues, whereas previously this population hadn't been looked at. If you saw a single amino acid change in von Willebrand factor in a patient with low VWF or who you thought had von Willebrand disease, of course that must be the causative mutation. But as we're sequencing more and more individuals, we're starting to find out VWF has a lot of heterogeneity. So one issue is you have to be careful. Some of these variants were seen in almost 20% of the African American healthy controls, so highly unlikely that they are the causative variant. Could some of these still be playing a role? I don't think we know for sure, but any novel variant needs to be interpreted with caution because it may not necessarily be pathogenic. The other issue is that there are modifiers beyond VWF. So it's long been known that ABO blood group affects VWF. Type O is associated with lower VWF levels. But a number of other interesting proteins have been implicated. Several of these were initially found in a large genetic association study, but the Willebrand group has shown that CLEC4M is a receptor that binds and clears VWF, and variations in this can affect your VWF levels. SCARA5 is a scavenger molecule that has been implicated, as well as STAB2B and syntaxin binding protein 5, and possibly its binding partner STX2. TC2N, and then the newest addition, this ubiquitin fold modifier number 1, may also be genes that affect VWF levels. So simply sequencing the VWF gene may not necessarily give you an answer as to whether von Willebrand factor is having problems if you don't find a mutation in the VWF gene. It might be one of these other genes that is to blame, and this, of course, may not be a complete list. If we do genetic sequencing, mutations can be found, and this is a cartoon stolen from David Lillicrap out of Kingston, showing the location of von Willebrand disease mutations for the various types of von Willebrand disease. I think the great take-home point here is that, well, for the quantitative defects, type 1 and type 3, the mutations are spread throughout the VWF gene. For the type 2 variants, the things are much more clear and much more focused, and they focus to the area where the defect occurs. So if you have a type 2A variant with a defect in multimerization or increased cleavage, those relate to the multimerization sites or the cleavage site. Type 2B is a gain of function in platelet binding, so of course localizes to the A1 domain. The type 2M defects localize to the platelet binding or the collagen binding domains. Type 2N von Willebrand disease localizes to the factor VIII binding domain. So if you are performing genetic analysis for a type 2 variant, you may not actually need to study the whole von Willebrand factor gene. To contrast, if you're looking for a type 1 or type 3 variant, you can't isolate your focus to one specific area. Type 1 von Willebrand disease is the most common type and probably the area where genetic testing would be most useful, but some issues with this arise. One is that it's autosomal dominant inheritance but variable penetrance, so different family members may have the same genetics but a different phenotype. Most mutations are missense mutations, but large deletions have been reported, and I'll show you some data on this in a moment. Sequence variations have not been picked up in all type 1 subjects. They're found in about 2/3 of type 1 von Willebrand disease subjects. And although antigen correlates directly with the likelihood of genetic variation in VWF, bleeding scores don't always correlate well with von Willebrand factor level. So large deletions can cause von Willebrand disease. There are a number of these. The one I'm showing here is the most common, which is the exon 4 to 5 deletion. And these large deletions are not picked up by conventional sequencing. So this picture is showing a comparative genomic hybridization to get at allele frequency. There are a number of probes interspersed throughout the VWF gene. It's actually read backwards from right to left. So this is exon 1, this is exon 52 at the far left. And when you have 2 copies, you're going to hover around 0, which is where most of these probes are. Gain of an allele would give you a plus number. In this case, you have loss of an allele for a region that corresponds to exons 4 and 5. These are not going to be picked up using your conventional sequencing. A number of studies have now been performed looking at genetic variations in type 1 von Willebrand disease. This is data from 5 large genetic studies on type 1 von Willebrand disease, a UK study, the European Union MCM-DM1 von Willebrand disease study, Canadian study, a German study, and then the Zimmerman program. And on average, it's very nicely coming out at around 65%. About 2/3 of patients have a sequence variation in von Willebrand disease, which means 1/3 of patients do not. I am not going to get into the other issue, which is, do we know for sure that the variants we're seeing are in fact the disease causative variant, which we might not for all these individuals. And again, not all these groups did comparative genomic hybridization to look for all deletions that might be occurring. So again, the numbers might fluctuate a little, but we're still missing a significant number of type 1 variants. We do a much better job in type 2. This cartoon is borrowed from Anne Goodeve's recent review, which again shows that for type 1 and type 3, the number of mutations per exon is very, very, very variable. For type 2A, for 2B, 2M, and 2N, there's much better localization, and they localize specifically to the functional domain that you would expect based on where the problem lies. So to summarize the genetic issues, not all subjects have a sequence variation in VWF. Novel variants do not necessarily represent von Willebrand disease. Type 2 von Willebrand disease defects generally localize to a specific region, so although VWF genotype may not be helpful in type 1, it probably is for type 2. And of course, we may be missing variants in other genes or large deletions when we do this type of sequencing. So I want to use the last few minutes I have to just discuss a common clinical conundrum many of us face. What is type 1 von Willebrand disease? Several guidelines have suggested a cutoff of 30 units per deciliter for a diagnosis of type 1 von Willebrand disease. Many of our labs have a lower limit of normal that's around 50, leaving a low VWF population that we don't know what to do with. The NHLBI consensus guidelines used 30. The UK management guidelines, which were published in the last several years, used a cutoff of 30. And confirmation of this cutoff was also found in a multi-center Spain cohort. To support this, healthy blood group O subjects have a normal range of VWF antigen that goes down to 36. And obviously, all our healthy blood donors don't have von Willebrand disease. Genetic variants are also most common when VWF antigen is less than 30. So it has been proposed that low VWF may be more of a risk factor for bleeding. Similar to how factor V Leiden is a risk factor for thrombosis, low VWF may be a risk factor for bleeding and not necessarily a disease. This may be very nice in theory, but sometimes it's hard to know what to do with this when you're faced with an individual patient. I did pull some of our data from the Zimmerman program looking at sequence variants by antigen level, and we did have a similar cutoff of 30. So this is antigen grouped in groups of 10. For antigens less than 20, over 90% had a sequence variant. The dark blue was those who had a sequence variant, light blue was those who didn't. 20 to 29, it was about 3/4. And then in between 30 and 50, it was about 2/3-ish. Once the antigen got above 50, the rate was similar to that seen in the healthy controls. For anyone who's wondering how you could have a diagnosis of type 1 von Willebrand disease and have an antigen over 50, for the Zimmerman program, we did take subjects with a pre-existing diagnosis, many of whom did not have abnormal testing on repeat analysis. But despite this change in the genetic variants, there was not a similar change in bleeding score. So if you look at the number with an abnormal bleeding score, shown in the dark blue, you can see that 30, 40, 50, regardless of the antigen level, there were still a significant number with elevated bleeding scores. Does this mean patients with low VWF bleed? Does this mean they have another diagnosis? I don't know that I can say for sure. I can tell you my thoughts, which are, 1, a family history of bleeding is technically required for the diagnosis of von Willebrand disease, so this testing probably should not be performed in somebody who doesn't have a personal and a family history of bleeding. That will avoid doing this testing on patients that are asymptomatic. Again, as a pediatrician, this is easy to say, but sometimes we're faced with a patient who's very young and has no family, and we may not know what to do with them. Repeat testing at some point may be medically indicated for borderline lab results or if you suspect a stress sample. And we've all had cases where we've repeated the testing and it's come back much lower than that original sample. I will say we generally diagnose as von Willebrand disease if bleeding symptoms and family history are present, even for those patients that fall in that 30 to 50 group, on the basis that patients with bleeding may benefit from treatment. But I think this is an evolving area and definitely merits more study because we certainly don't want to be giving people a diagnosis that they don't deserve and subjecting them to treatment that they don't actually need. So to conclude, bleeding assessment tools may allow better stratification of our patients, and anything that lets us not do complicated testing will not only save money but also help provide the best possible care to patients. There are new assays of VWF platelet interactions which may replace, and in some cases have replaced, the ristocetin cofactor assay and its associated limitations. Collagen binding assays may identify specific defects in VWF function and may be helpful in the diagnosis of variant von Willebrand disease. And genetic testing is probably most useful in the type 2 variants and probably not useful right now in type 1 von Willebrand disease. So I will stop there. I will acknowledge all my von Willebrand factor and Zimmerman program colleagues that do most of the work that I get to discuss, and also all my international colleagues whose work I've presented and who have advanced the field. And I would be happy to take any questions from the disembodied audience. Thank you.
Thank you very much, Veronica, for this tour de force, a superb review going from clinical to genetic aspects of von Willebrand disease. While I take a look to see if there are hands that are being raised electronically through a web panel, perhaps I'll take the liberty of asking for a, let's say, hardcore clinician who I dare say doesn't have in the palm of her or his hands all of the notions of genetics that you've briefly summarized to us. But you've clearly shown that polymorphisms and mutations were perhaps starting to understand the phenotype better and tailor laboratory testing that unravel some of these mutations, particularly for patients that will never go away. I'm going to take the label borderline. They bleed on and off, and it's hard for us to conclude if they have von Willebrand. Do you foresee a future in which the addition of the collagen binding testing or platelet interaction testing will ultimately become an algorithm? If they test borderline, but the bleeding score is this, follow with tests A, B, C, and D to help the clinicians that may not necessarily know all of the genotyping implications, but because of the genotype-phenotype interactions you've described, will have a better algorithm to diagnose von Willebrand. I don't know if I make sense with my question.
Sure. I think it would be lovely if we had a better diagnostic algorithm. I'm not sure with that borderline group, though, where we're going to go with that, because there's a couple possibilities. One is that some of these patients represent something within the normal range of bleeding and don't actually have a bleeding problem. What one can say is that some of these patients do benefit from treatment, and so removing their diagnosis isn't necessarily helpful. And more diagnostic tests, you might just be spending more money. On the other hand, von Willebrand disease is not the only bleeding disorder out there. Many of these patients may have platelet function defects. I know in our study, not all patients with borderline levels had platelet aggregations done, and so we may be missing other diagnoses. It would be nice if we could come up with a straightforward testing algorithm for von Willebrand disease, but I'm not sure with the issues of potential stress, and of course with women, you know, some people will say, well, if they were tested while they're on hormones, we want to retest them when they're off hormones. It can be very challenging in that group. So I don't think we're there yet, but someday maybe, although that testing is also going to have to involve looking for other defects that could cause bleeding besides von Willebrand disease.
Okay, thank you very much, Veronica. Let me see if we have, it looks like we have a question from Brenda Gallagher's group. Let me ask my coordinator to open the mic to see if that is correct. So the Brenda Gallagher's group, your microphone is open in case you have a question. Please come forward. Nope, there is not the case. Anybody else that you see, Madeline?
See, I knew no one was really listening.
Let me open the microphone at the floor of the Sick Kids conference room, and we'll give them the podium. Please come forward.
Well, I'm here. So, Veronica, can you hear me?
Yes.
Okay, so this is Manuel Carcao from Sick Kids. How are you?
I'm good. How are you?
Good. So you mentioned that there is no physiological shear-based test for von Willebrand's disease. You also mentioned that there is acquired von Willebrand's disease. And, you know, this is obviously a diagnosis that has not been that well studied, with maybe the exception of the Milwaukee group, who has conducted a number of studies. But, you know, I have found that we don't have a great test for it. And with these newer ways of assessing activity of von Willebrand factor, whether it's direct binding to GP1B or to collagen binding, do you think that those are going to help us with acquired von Willebrand's disease in all of its different forms? And the other thing is, you didn't mention PFA, and I was wondering if you can comment on PFA and its utility.
Sure. Yes, because the PFA, I guess you could call a shear-based assay. So I'll tackle the PFA issue first. So as you probably know, there are several groups that have looked at the PFA in trying to diagnose both von Willebrand disease and mild platelet function defects. And unfortunately, the sensitivity and specificity just aren't there, at least for the mild. I think, you know, severe von Willebrand disease, you probably would pick up with a PFA just as a major platelet function defect, you will, but those generally aren't diagnostic conundrums anyways. It's the mild VWF group that are the troublesome ones, and it's those that are just as likely to have a normal PFA result. And conversely, we have a number of patients we see, because our center, unfortunately, our hospital loves to get it as a screening lab, and a number of them never turn out to have any sort of coagulation defect. So for mild bleeding disorders, it is certainly not a perfect screening tool. For acquired von Willebrand disease, which we're getting more and more reports of, especially with various new things they can do to fix your heart for you when it stops working, those issues are interesting because I don't know that the GP1B binding or the collagen binding always correlate with multimers, and I also don't know that either of those correlate necessarily with the bleeding that's seen in the patients. So I'm going to have to defer to other experts to solve that one, just because I'm not sure that we're at a point where we can use any of those as a predictor. It's
and maybe just
a risk.
Maybe just as a follow-up, Veronica, you know, when we do see these patients with mild von Willebrand's disease, so type 1, sometimes these patients will actually show very abnormal PFAs, and others will show quite normal or almost normal PFAs. And, you know, it was interesting when you mentioned that 5% of type 1s have a defect in collagen binding. And do you think that the collagen binding may correlate more with the PFA? Just because if you think of the PFA, it's collagen ADP or collagen epinephrine, so there is collagen binding in the PFA.
Right, it's certainly possible. The PFA uses type 1 collagen. They haven't disclosed to us exactly what the concentration is, but it is type 1 collagen. So certainly, generally though, the more common collagen defects we've seen are the ones that affect collagens 4 and 6, and most of those don't affect type 1 collagen binding. Although the domains are supposed to be able to substitute for each other, the mutations, or I should say sequence variations that we're seeing in patients seem to be specific to one or the other. So it would be great if we could get them to redo the PFA with a collagen 6 cartridge as well. And maybe that would be more specific. I don't know. It would also be interesting if any of the Kingston group are on the line, if they want to correlate PFA with bleeding scores, because maybe that's a signal that those are the patients who are going to have more significant bleeding. And I don't know that anyone's done that analysis.
Are there any other questions from Sick Kids or from Dr. Carcale?
Negative to both.
Madeline, did we have any electronic hands raised from the panelists? Okay, the answer was no, so we're 3 minutes off the top of the hour, and if this is correct, then we'll be able to thank again Veronica for her superb presentation on von Willebrand, and thank you everybody for your attendance. This ends the annual efforts for the CPTA Gen webinar series for 2017, and we'll be seeing you along in Toronto for the CPTA Gen meeting. Thank you again, Dr. Flood.
Thanks for having me.
Thank you all.